So welcome everybody. Good evening. Um, my name's Emma Williamson, and I'm a member of staff at IRISi, Iris Interventions, which is a UK social enterprise, and I'll explain a little bit about that in a moment. But welcome to the Victim Protection in Medicine European Webinar Series, and I'm very pleased to be giving this talk this evening, looking at spotlight on domestic abuse and sexual violence in sexual health settings. Before I start, I want to give a normal caveat, really, just to let you know that it is important that we think about self-care. We know that domestic abuse and sexual violence are sensitive and can be difficult topics to discuss. So I ask that you please look after yourself and do what you need to do to keep yourself okay. My name's Emma, and I've worked for IRISi for just over 3 years. But I have worked in the area of domestic violence and health for about 30 years. Before working at IRISi, I worked at the University of Bristol in the Centre for Gender and Violence Research and conducted research around a whole range of different types of gender-based violence and violence against women and girls. Published widely on the topic of domestic and sexual violence, and also engaged in a number of different European and international research collaborations. So hopefully, if you have any questions at the end, I'll be able to answer those questions. I believe you can put questions in the Q&A function during the talk, and you can also put messages in the chat. I'll be doing the presentation, and then I'll stop sharing the screen, and I believe the recording will stop at that point, and then you can ask any questions that you want to. So if you have any questions, please pop them in there, and I'll go through them at the end when I've finished the presentation. So in terms of the content that we'll be covering today, I'm going to talk a little bit about an overview of IRISi, thinking about our vision, mission, and the work that we do as an organisation, giving a brief overview of domestic abuse and sexual violence in the United Kingdom, although I am aware many of the issues, many of the statistics, particularly around prevalence, will be very similar across different European countries. I'm also going to refer to domestic abuse. You'll see on the slides DA, and sexual violence as SV during the talk. So just so that you're aware of that. Obviously, there are some overlaps between the two, so it is important that we think about that as well. I'm going to talk about the health impacts of domestic abuse and sexual violence, introduce the advised model intervention so that I can give you a clear understanding of what that is and how it works, as well as thinking about the evidence that we have from that intervention and the critical role of sexual health clinics in supporting victims and survivors, and really thinking about why sexual health clinics are an important site in which we need to be having these conversations in a safe way that supports patients but also supports staff as well. And I'll be referring to, depending on the time, 2 or 3 real life case studies from anonymised patients that have been supported by the advised intervention, and thinking about some of their health outcomes and some of the ways in which that support has operated. So as I've said, IRISi is a social enterprise, and it's dedicated to improving the healthcare response to gender-based violence. And we try to bridge the gap between healthcare professionals and domestic abuse or violence against women and girls services. So our programs provide specialist support to victims and survivors of both and domestic abuse and sexual violence. We also provide expert advice and consultancy in the field of gender-based violence and health, and scaling up our evidence-based commissionable programs across the country. And I'll give you some statistics and data around that in a moment. We work with academic colleagues to develop innovative new evidence-based solutions, providing expertise at the health gender-based violence intersection, and we work alongside sector colleagues to champion this work at a national level as well. We think it's really important that specialist services, specialist domestic abuse, specialist sexual violence services are working alongside and collaboratively with health, and we work to try and strengthen those partnerships. We're the only national-based organisation specifically working across and within healthcare to improve the response to domestic and sexual violence. and we exist to amplify and push for the need for a healthcare response to gender-based violence. So our ambition is to develop a suite of interventions and training support to clinicians so that they can recognise and respond safely to the needs of patients affected by domestic abuse and sexual violence in a wide range of healthcare settings. So I'll be talking in more detail today about two of our programs, but there are other areas in which we provide that training and that support. We want to ensure that healthcare professionals are supported to confidently and safely address the issue, but also to understand the impact that this has on victim survivors' health, both physical and mental health, and to recognise that often this is a direct result of the abuse that they've been subjected to. We also recognise in our work, and we've been involved in research that's looked at this issue in particular, that it's important to recognise that a large population of our healthcare professionals will also have been personally impacted by the issue of abuse. And so it's important that support is provided in this area as well. So recent research showed that healthcare professionals' lived experience of abuse can impact on how they interact and respond to patients. So that is an integral element of the programs that we run. So it kind of makes sense. If you've had lived experience, you may be reluctant to ask patients about it. You may be fearful of how you might respond as a healthcare professional. So it's really important that we recognise that and provide the support that's needed so that those clinicians have the tools available to be able to give their patients the best care that they can. So IRISi launched as an organisation in 2017, but has working and running programs in healthcare since 2011, so nearly 15 years ago. And we're made up of a very small team of women who have, in the most part, worked within the violence against women and girls sector, supporting victims and survivors and clinical teams, and working within violence against women and girls research for many years. And looking ahead, and I think this is where we fit quite well with the VIPROM program itself, is that our vision is a world where gender-based violence is universally recognised and addressed as a critical health issue. And to achieve this, we think it's important to expand evidence-based programs and provide expertise at the health gender-based violence intersection, collaborating with those partners on the ground and develop innovative solutions to advocate for change at national level as well. And just to finish that in terms of IRISi, we are driven by hope, resilience, and a commitment to creating a future where every survivor of gender-based violence has access to the care and support that they need to thrive, whether that's within a health setting or outside of a health setting as well. So thinking about what we provide, so IRIS is an evidence-based intervention which seeks to improve the general practice response to domestic abuse. So obviously in different countries, how general practice or primary care is run and organised will be slightly different. But general practice in the UK context, IRIS launched as a commissionable model in 2011 and has grown significantly, supporting nearly 44,000 patients since its inception. It came from research and was based on pre-existing research about the prevalence of women attending general practice who had been experiencing domestic abuse. A randomized controlled trial was run of the IRIS intervention where it was found to be effective. So it's an evidence-based program, and that research found that it was meeting an unmet patient need. So in many cases, patients weren't being identified. The issue of domestic abuse was not being put into their medical record, and they weren't necessarily being referred to specialists who might be able to help them. So IRIS as an intervention is now the gold standard intervention for general practice. It has informed the NICE guidance. So in the UK, the National Institute for Clinical Excellence, their guidance on domestic abuse, recommendations 15 and 16, recommend IRIS as a model. And that model has informed their thinking on how to respond effectively within primary care. And it's also been used to inform the quality standards that have been published to support those recommendations. So Advise is our second intervention. It was launched in a number of sites across the UK. It's now in 6 sites in the UK. It uses the same model which has been adapted from primary care for sexual health settings. And That program developed from research that was conducted by Lorraine Bacchus at the London School of Hygiene and Tropical Medicine, and it was developed as a result of a need to look at how to reach hard to reach populations who may not access the general practitioners. So sexual health services were one of the sites in which that initial research took place to see if they could identify male victims of abuse, but also other people who may not readily access primary care services. As you can see there, 57 commission programs across the UK, just under 44,000 IRIS referrals, and in the 18 months that it's been running, over 1,000 referrals to advise in terms of from sexual health clinics. So both programs, IRIS and Advise, offer comprehensive specialist training to all practice and clinical teams, and they cover something which we refer to as the 5 Rs, which I'll come on to in a moment. So this training is ongoing. It's not a one-off training session. It provides refresher training and mop-ups for new staff if you have changes of staff. And we know that this has the highest impact in terms of change because it is an ongoing support consultancy service, so that that knowledge can be maintained within practices where there are clearly competing demands, whether those are competing demands in terms of workload or competing demands in terms of national guidance and national priorities. So it's really important to have that ongoing interaction and intervention with staff and practice teams so that there's a clinical team awareness. It's not left to one individual within a setting. It's the responsibility of everybody to think about how they might respond to patients where domestic abuse or sexual violence is an issue. Both programs also provide, as well as the domestic abuse sexual violence specialist, which we call advocate educators, so AEs. You will see that as we go through the slides. We also, in most cases, have a clinical lead. So that will be somebody who is a clinician, either in primary care, if it was for the IRIS program, or somebody working within the sexual health clinic who provides ad hoc guidance and support. And they receive the additional training that we provide. And they also co-facilitate some of the training that's delivered to clinical teams. So they will have more knowledge, for example, about how to record things in the different medical record, and they can also talk about some of the barriers that clinicians might face, as well as advocating that clinicians refer into the specialist advocate who will be supporting patients as well as providing that consultancy and support. The advocate educators are often co-located or based in the practices or sexual health clinics at least part of the time. And they provide a direct, simple and fast referral pathway for support for patients who are aged 16 and over. Within the IRIS program, they mainly focusing on domestic abuse, which may include elements of sexual violence within that, mainly focusing on female patients, depending on what has been commissioned locally. Although there are alternatives to that, so some sites will provide support to all patients, male and female, as well as providing support around domestic and sexual violence. Advise is available to all patients and includes both sexual and domestic abuse, and both of those programs support both patients and professionals. So thinking about the Advise program, so we've had over 1,000 referrals in the 23 to 24 fiscal year. We've had slightly more since then. But in terms of an evaluation of that program, what we see in terms of IRIS to start with is that when we look at the referral outcomes, so the individual patients who report on IRIS after they've had an intervention, that they report on both their physical and emotional well-being being positively affected. They also talk about a positive effect on their children and wider family. Women also perceive that these impacts would be long-lasting. So women accessing IRIS rated their self-esteem on average 0 to 1 before support, and on average 8+ after IRIS support, and that was on a scale of 1 to 10. So this demonstrates the significant impact that the program has on improving women's mental health. And And a pre and post analysis of health conditions found that there was a significant difference in the health conditions before and after IRIS support. So patients had fewer health complaints. They also reported accessing health services less as a result of the support, which kind of makes sense in a way, because if you're not addressing the underlying reasons why somebody is attending a healthcare setting, then it's likely that those patients will need to keep coming back. Whereas if you actually deal with the underlying cause of the symptoms, then actually it can have significant impacts on that patient's well-being and on their health as well as having a significant impact then on the health setting itself. We know health services are overstretched, so it's really important that those positive outcomes can be identified, evidenced, and then discussed. Thinking about advice in particular in terms of sexual health clinics, so the evaluation that was conducted in the first site in Manchester, many patients responded to questions when they were explicitly asked about domestic or sexual violence, and they did disclose abuse. Almost all of the people who were interviewed in that evaluation reported an increase in disclosures. And in some cases, this was considered to be a considerable increase, and particularly historic abuse. So, where people may have accessed services but not disclosed abuse previously, they were able to do so because they were being asked as by a team that had been trained to feel comfortable to ask those questions. We also find that we get more men in the advice sites. So in Manchester pilot, there were 22% of the referrals were from male patients, which is higher than we would find in general practice in the IRIS comparative sites. Also, and part of this is because of the fact that many sexual health clinics will be located in urban areas, so where people may travel in to access those health services, that we also have a higher representation, also higher than the local demographic of Black ethnicities. So, and that was both people identifying as Black or also Black British. So we see that in the advised referrals as well. So we're reaching a more diverse population than we might in general practice. And we also have higher rates of LGBT plus patients disclosing than have previously been seen in other clinics. More commonly, disclosing sexual violence, there was reflections around the need for support with historic abuse. So one of the clinicians who responded to the evaluation said there'd been a marked increase in patients being referred due to sexual abuse, both current and historic. And also some referrals where patients were experiencing sexual abuse that was happening within the context of domestic abuse, as well as in isolation. Staff reported that advisors had increased their capacity in the workforce because they were able to refer patients to the specialist support. And also there was a notable increase in staff's understanding of the health impacts, and also their increased knowledge around harmful practices, or sometimes referred to as harmful cultural practices, which is included in the training that they're offered through these programs. So just flagging here in terms of advise. Advise stands for, it's quite a strange acronym, but it works for us. Assessing for domestic violence and abuse in sexual health environments. It has there the 5 R's. So what we start with and what we end with in the training to clinicians is an acknowledgement that we want clinicians to be comfortable to recognize, ask and risk check, respond, refer, and record where domestic abuse or sexual violence is an issue. As I said before, Lorraine Backus at London School of Hygiene and Tropical Medicine conducted the first study, which was looking at implementing IRIS within sexual health clinics, and that published peer-reviewed papers around that are available. It reaches those diverse and hard to reach populations who may not access other general practice primary care services. So it's really important in terms of increasing the number of referrals, and it improves the quality of life for patients because they're getting that specialist support that they need. So looking at the model, We have a series of inputs here, the things that are offered, outputs, and then outcomes. So that training and ongoing support, I really must stress the importance. This is not one-off training. This is about having that relationship with a trainer who can come back in, who can answer questions and provide that clinical consultancy. Often when we do the training, I like to make the comparison, certainly in primary care, if somebody came in with a heart condition, the general practitioner would refer them to a cardiologist, and we want them to do the same thing here. If somebody comes in who's been affected, their health's been affected by abuse, we want them to refer to the specialist, and in this case, that would be the specialist domestic abuse, sexual violence worker or advocate. So they get that training and ongoing support. There's care pathways that include thinking about normal safeguarding around children and adults. There's questions around how we record, how we flag cases within the specific setting. So in advise, how are we going to record domestic or sexual violence in the sexual health record? You have the advocate educator role, you have the clinical lead role, you have health education materials. So we, as well as providing training, we provide all of the academic papers in the model so that those who want to go away and read it and do more work can do so. We talk as well about clinical inquiry, and the way in which we talk about that is around professional curiosity. So trying to really encourage clinicians to use that professional curiosity and feel comfortable to ask about abuse if they feel that that's something that's relevant for that patient and that patient's needs. Validation, it's really important not just that we ask, but that we respond appropriately. How we then document that in a safe way, especially with the increase in technological medical records, so the access that people have to documentation, although that's different in sexual health clinics, it's important to think about how we document it in a safe, consistent, and helpful way. And we also do, in terms of the inputs, put all of that training in the context of immediate risk assessment. So what is it that clinicians need to do, and is there an immediate risk that they need to address? In terms of outputs, we have identification, referral, advocacy, emotional and practical support, evaluation and monitoring, and then thinking about the outcomes for the patient. The aim is to have improved quality of life, improved physical and mental health, a reduction in abuse. We don't claim that we can stop abuse, but it is important that people can be supported so that that can be reduced, to increase safety. And for the sexual health professionals, an improved response around domestic abuse and sexual violence to enable them to provide holistic care. So recognizing where abuse might be undermining treatment or being potential cause for symptoms. And finally, in terms of the clinics as a whole, not just the individual professionals within it, having that domestic violence or sexual violence aware clinic, and that they're resourced, so posters, leaflets, etc., so that everybody knows this is somewhere that's safe to disclose and somewhere safe for clinicians to ask. So as well as the two programs that we currently run, those two programs, and I'll talk a little bit more about advise in a second and some of the health implications, but we're constantly looking to replicate the impact of IRIS in new areas, working alongside researchers to develop other evidence-based interventions into commissionable models, and we have a business development team that focus on that work, so we work with researchers and others to develop that. Yeah, so at the moment, in terms of the specific areas, as well as looking at IRIS in health broadly, and looking at general practice and sexual health, we also have been doing work around maternity services. We have a health visitor model running at the moment, a pilot. We've provided services training for pharmacy. So particularly if pharmacists are linked to general practices or other places where we conduct training, they are often included anyway, but we do provide additional bespoke training for those teams if they require it. Termination of pregnancy services, dentistry. We've done a number of sessions to train dentists, looking at the impacts and work training dentist students. Armed forces, they often have their own health structure. We've done work around that to think about how, as a community, that's an area that's important that we recognize some of the specific differences that exist when we're looking at abuse in that context. School nurses, and also looking at mental health teams who may be embedded in different places, depending on how they're run in different areas, certainly in the UK. So I'm assuming that would be different in different areas across Europe as well. Okay. So you have a brief task here. So just whilst I take a sip of water, I'm going to ask you to pop into the chat what you think the answer to this question is, please. So yeah, gynecological issues are the largest physical health impact on women who are subject to domestic abuse compared to those who are not. And that comes from the World Health Organization data. And women who experience domestic abuse are 3 times more likely to present with those issues. So it's really important for us that we think about those health settings where gynecological issues are going to be flagged, and that those clinicians have the confidence and that they're comfortable to ask questions when they need to be asked. So thinking about prevalence, and this is, I think the rates are likely to be similar across different countries, but certainly in the UK, we do recognise it as a national crisis. It affects 1 in 4 women and 1 in 6, 7 men in England and Wales. In the year ending March 2024, the victim was female in 72.5% of domestic abuse related crimes. That comes from the Home Office, Office of National Statistics. And earlier this year, the National Police Chiefs Council declared that violence against women and girls was a national emergency, noting that it had reached epidemic levels in England and Wales, in terms of both its scale, but also its complexity and impact on victims. According to the Institute for Addressing Strangulation, an estimated 20,000 victims in the UK experienced strangulation each year. And between April 2010 and March 2021, so 11 years, every year, on average, 18% of female homicide victims in England and Wales were killed by strangulation or suffocation. So certainly in the UK, we now have legislation around non-fatal strangulation, which is included in our training because of the health impacts and the risks and dangers that are associated with that. And I'll mention that briefly in a second as well. Despite these statistics, and they are overwhelming, domestic abuse and sexual violence are still not talked about enough. And around 85% of victims seek help from professionals on average 5 times in a year before they receive effective help to stop that abuse. Whilst we recognise that abuse is a gendered crime that disproportionately affects and impacts women and girls, men and boys also experience domestic abuse, and it's important to reflect that domestic abuse has no boundaries. Anybody can be affected by that. In terms of domestic homicide, so women are at an increased risk of domestic homicide. 65.4% of homicide victims were women, and 74.9%, so just under 75% of the suspects were male. And we know that domestic abuse and sexual violence is a health issue. And whilst healthcare professionals are in a unique position to identify and respond to patients experiencing abuse, we do, as I mentioned earlier, need to not overlook the fact that healthcare professionals will themselves have potentially experienced abuse themselves, but will also face their own unique barriers to how they disclose and how they might individually seek support. So I'm just going to move on now to thinking about some of those health impacts and those health issues. The question, are domestic abuse and sexual violence health issues? The short answer is yes. But in terms of the data and what we know, thinking about both sexual violence and domestic abuse, we know that healthcare services in the UK are often stretched. They're seeing patients with repeat conditions, complex health histories. But we also know that domestic abuse and sexual violence have a significant impact on health, but they're often not viewed as healthcare issues. Large numbers of patients attending sexual health clinics will be presenting with symptoms associated with abuse. And for this reason, it's really important that we have safe domestic abuse and sexual violence inquiry as part of routine assessments of patients. So the listed conditions may be present in patients who are experiencing either domestic or sexual violence or both. They're not mutually exclusive. However, the presentations in yellow are the ones more frequently associated with sexual violence, and those in blue are associated with domestic abuse. From research that was published by Potter et al. In 2020, they found, and that research was based on female victims, not all victims. So it is important to be aware of where our evidence comes from on that. But women who had experienced abuse were 2.3 times more likely to have issues with memory and concentration. They were 87% more likely to complain of pain or discomfort, 73% more likely to take pain medication, 86% more likely to take medication for sleep, 66% more likely to have been admitted to hospital for reasons other than labour. So we know domestic abuse, sexual violence aren't only physical, but we do need to recognise the physical injuries. So thinking about unusual bleeding, cuts, burns, bruises, repeat broken bones, and thinking about what the explanations are that patients give for these injuries. Do they make sense? For example, does the injury align with how the person said they fell or became hurt? Could they indicate assault or self-injury as well? In terms of those gynecological problems that we've already referred to, they are the most consistent, but they're also the longest lasting and largest physical health difference. So we're talking here around sexually transmitted infections, so STIs, urinary tract infections, painful intercourse, chronic pelvic pain, and vaginal bleeding may all be symptoms that we might want to be thinking about to think about whether we need to ask questions around domestic and sexual violence. Chronic physical conditions, so gastrointestinal disorders, fibromyalgia, chronic pain, chronic tiredness. And I think what's interesting in terms of these kind of chronic conditions is if you're living with trauma and you're living in an abusive relationship, or abusive situation, they can have a profound impact on victims and survivors' physical health, because when we're tired, stressed, it can take a toll on our physical health. So if you're experiencing a number of types of abuse, feeling anxious, afraid, nervous, constantly being under quite high levels of stress within the home, it's understandable that they will have an impact on our physical health, whether that's irritable bowel syndrome, those UTIs that I've just mentioned, insomnia, high blood pressure. All of those things may be more prevalent because of that stressful context where somebody's walking on eggshells, trying to manage what is a very difficult situation to manage. We also have evidence that experiencing domestic abuse may be associated with worsening menopausal symptoms, and that the menopause may lead to changes or escalations in domestic abuse. So there's some research that was conducted. Nearly 4 in 10 women killed by men in the UK are in the 36 to 55 age range. So that leads us to ask some questions about why. Menopause-related healthcare appointments can be a really key opportunity for intervention with women who may not otherwise disclose or identify their experiences as domestic abuse. And that can be in either general practice, but also can be in sexual health clinics, where there may be physical changes for menopausal women, which means that they may be reaching out for support and services, which gives us that opportunity to potentially ask questions. Child sexual abuse is also related to high rates of subsequent physical health problems. So in terms of general health, gynecological issues, pain, obesity, whole range of issues that can have as a result of child sexual abuse. People may be avoiding cervical smear tests, women who have experienced sexual violence, for example. And obviously, it's slightly strange to kind of flag it as a health issue, but the worst case scenario here is that the health impact might be death. 2 to 3 women are killed every week in England and Wales by a current or ex-intimate partner. And we know this is figures much higher if you include women also killed by family members and those who die by suicide as well as a result of abuse. And the final thing I want to mention in terms of the physical health issues is around non-fatal strangulation, which I mentioned previously. So whilst we can view it as a physical injury, or the physical injuries associated with it, we know the impact often goes far beyond perhaps bruising, etc. So there's a significant health impact which might include stroke, particularly in younger women, and that is as a result of the a blockage of not just airways but also blood to the brain, that can actually cause internal injuries which may not be visible to clinicians that they're looking at. So there's a suggestion that strangulation could be the second biggest cause of stroke in women under 40, and that brain injury, stroke, so bleeding on the brain, memory loss, amnesia, and impact on cognitive functioning and decision making can all be affected where somebody has been subject of non-fatal strangulation. So it's really important, and certainly in the UK and around in sexual health settings, if somebody is aware that if there's been a sexual assault and somebody has been strangled, that we're really clear about what the referral pathways are to ensuring that those patients receive scans and that they get that support that they need to just check whether there are any internal injuries. And within the detailed training that we provide to clinicians in those settings, we look at what some of those signs might be, for example. Thinking about mental health, I'm not going to say a lot about this, just partly because we know, and there's a lot more research on this, I think, and it's recognized in many other settings, not just in health settings. Post-traumatic stress disorder can be particularly relevant. Self-harm, eating disorders, anxiety and depression are certainly the highest impacts that we see. But thinking about the research, we know that women who have experienced abuse are 6.5 times more likely to attempt suicide and 4.9 times more likely to have suicidal thoughts. So the biggest impact on health outcomes is for women with experiences of both physical and or psychological violence and sexual violence. So those who have multiple experiences of abuse are likely to have the higher rates of these mental health issues that are listed here. So what's really important there, I think, certainly when we think about our training, is that clinicians, if they have a patient who they think is suicidal, are quite good at asking the questions. There are standard measures that we use, a PHQ-9, for example, in the UK. We use, you can tell me in the question and answer at the end if in your setting you use something similar. But we certainly recommend that if you're asking those questions, you also ask a question about whether or not somebody is being harmed. And we also, when we're doing training around perpetrators, for example, if a perpetrator is suicidal, and we know there's a link between homicide and suicide with people, perpetrators who kill family members before killing themselves. If you're asking those questions around suicide, it's really important. You can add an additional question that checks that they aren't going to harm somebody else as well. So just something that we put in the training that's really helpful, I think, for clinicians, because it's something that clinicians are already doing. So it's about recognizing that and recognizing the skill that clinicians already have to do that is really important as well. Pregnancy and antenatal impacts, again, really, really important. So around 30% of domestic abuse begins during pregnancy. 40 to 60% of women experiencing domestic abuse are abused during pregnancy. If domestic abuse is already a factor, then pregnancy can exacerbate the way in which that abuse takes place. There's no concrete evidence as to why that is, but it can and has been attributed to jealousy of the partner getting attention, or a partner not having control over her changing body, or knowing that the woman is much less likely to leave and end a relationship if she's pregnant. So midwives should be routinely asking about domestic abuse, but it's really important that in sexual health clinics and primary care as well, that staff and clinicians don't assume that midwives have done that or that it has been done appropriately or safely. So it's still important that all clinicians are asking the question, because if somebody isn't able to ask, then somebody might fall through the cracks there. So women who've experienced domestic abuse are 5.4 times at greater risk of having a miscarriage, more likely to have multiple terminations, and to report unwanted pregnancies. And women who have been raped have a 15 times increased risk for cesarean section during their first delivery, as well as having an impact on probability of low birth weight. So again, we can see all these different impacts on the health of patients where domestic abuse is the underlying issue. And so it's really important that we flag these and pick them up. So we think about, in sexual health clinics, think about women who might be repeatedly attending for the morning after pill, or seek hidden forms of contraception, perhaps mention their partner's opinion in relation to their contraceptive choices. And also thinking about patients who might be frequently pregnant with pregnancies that are very close together, or where it doesn't appear that they have much control or choice over that. And in these situations, it's really important that there will already be safeguarding concerns and procedures in place, but we need to be aware of that and thinking about asking about domestic and sexual violence. I'm also just wanted to flag here as well in terms of harmful practices. So if a woman's experienced female genital mutilation or cutting, she's likely to require additional support around the pregnancy and during the pregnancy. And it is really important, again, to remember the safeguarding responsibilities that clinicians have around that for female children born where the mother has experienced FGM or cutting. So it's really important that we think about that as well. So I'm just going to talk through a couple of the case studies of patients who were referred to advocate educators. So they were referred to specialist support by clinicians in sexual health clinics. So we've obviously changed all the names, but just to give you some indication of where this has been used in practice. So the first case study is a woman called Sarah. She was a 33-year-old white European woman with a 7-year-old daughter, and she attended the sexual health clinic in October 2022. The doctor asked whether she'd experienced domestic or sexual violence, and she disclosed that she had experienced domestic abuse from the father of her daughter and that they have now separated. So the advocate educator was at the clinic at the time of Sarah's appointment, so she was able to see her immediately, and she was able to complete the more comprehensive DASH risk assessment and safety planning. We don't expect clinicians to do those risk assessments, the comprehensive ones, because in most cases they don't have the clinical time to do it, but also they haven't necessarily had the training. But the advocate educator will have had that training and is able to implement them. So she completed that assessment and safety planning. Sarah had concerns for her daughter in terms of the father trying to get in touch and the domestic abuse that her daughter had witnessed. Again, in the UK, since we've had the Domestic Abuse Act, where children have been recognised as victims in their own right, that then gives us some leeway in terms of interventions here. Some practical things that were done. So personal alarm and door window alarms were provided for Sarah in her residence. And the advocate educators supported the client by speaking with children's services so they could offer some advice and make a referral into the local domestic abuse children and young people service. The advocate educator also supported Sarah to access a solicitor's appointment and was informed of her rights as a parent and her ability to withhold contact with the perpetrator where there were concerns prevalent. Sarah had a lot of guilt about the impact of the abuse on her daughter and putting boundaries in place. So the AE and Sarah talked this through. The AE was able to give reassurance that Sarah was doing the right thing, that the abuse was not her fault, and work with Sarah on building her confidence, processing her experience of abuse whilst keeping herself and her daughter safe. And at the end of the support, Sarah said it was really helpful to have been asked and listened to by the doctor and then to be referred into the service. And she was very grateful for that support. So that's really important. You can see there that the advocate educator has the time and the resources available to actually do a lot of work. A health clinician isn't going to be able to do all that work. So it's really important, as well as training, that there is that link into that advocacy and support, and that needs to be funded so that that work can be done. The second case study. So Keon was a young Black British man in his early 20s. And in the clinic, he disclosed for the first time that he'd experienced sexual abuse during his childhood. He was quite shocked to have disclosed that he was quite shocked that he'd done this, and he took quite some time to decide whether to accept a referral to an AE or not. But when he did make that decision, since then he'd made excellent use of the support provided. He explored his uncertainty about his sexual orientation and also got support to deal with his drug use and depression. He still lives at home with his parents, but family relationships had become problematic. So the AE was able to support Keon in terms of registering as in priority need for housing and to look at some of those practical steps to enable him to actually move forward and have that space to do the clinical work required to address that. And the final case study is Jamie. Jamie's a non-binary identifying 31-year-old who attended the transgender clinic at one of the sexual health clinics. And during that, they disclosed that they were currently going through domestic abuse and they consented to a referral into the program. Jamie is disabled, has multiple physical and mental health conditions. They also have a diagnosis of autism and are awaiting assessment for ADHD. At the time of the referral, Jamie was still living in the same house as their ex-partner, who was a perpetrator of abuse. So the AE was able to make contact via email, arranged a phone call, and then had a face-to-face appointment, and ensure that Jamie felt comfortable accessing support through advice. Was also able to make them aware of specialist LGBT plus services, so in this case the LGBT Foundation, who were also able to offer support around domestic abuse. And Jamie felt comfortable to continue working with the AE alongside that additional support. Jamie had a lot of anxiety around phone calls, provided a copy of their access needs statement so that they could help inform the AE's support, and a robust risk assessment and safety plan were completed with Jamie face to face. The AE encouraged Jamie to raise any issues around support so that it could be improved to work in the best way possible. And that resulted in Jamie able to find a private rent away from the perpetrator and somebody to share the house with, and they now moved into that new property. The AE was able to review the risk and safety plan and offer practical support in terms of new house setup. So some of the practical things that were difficult for Jamie to deal with, and also offer support in processing the experience of domestic abuse and encouraging Jamie to rebuild their confidence and support networks so that they're able to feel themselves again. Ultimately, the AE is continuing to support Jamie in rebuilding their life and ensure that they have the resources available to thrive. So just a few quotes here. This is the feedback that we have around advice. So from patients, service users, feel much better. It has really helped to know that there is someone I can speak to who will support me. Just mentioned it in passing. I didn't expect there to be any help provided, but now I'm glad I was asked. So again, the importance of actually asking patients that, sometimes they're quite surprised. Patients, in terms of sexual health nurse, patients are welcome being asked, and also it being a good service because there is a direct person that they can refer to, a really clear, simple referral pathway. So just thinking about what the data says, so 1 in 2 service users coming through the advice referrals with sexual violence. So the sexual violence element is much higher in sexual health clinics, as we might expect, because there are conversations happening around sexual health than we get in the primary care setting. We have a younger patient cohort referred, and again, this is really important, and especially with male patients, younger male patients there, more LGBTQ plus patients actually being identified and then being able to be offered support. So that the service is clearly meeting an unmet need. Some of the issues that we need to think about in relation to that is longer term funding is needed. Clearly it works, so we need to make sure that it's available for all patients. We still see some gender-based violence trends. So although we do have that increase in male patients, the majority of patients who are referred to through are still female. But it's also really important that we recognize that 92% of the perpetrators were men. So even where we had higher numbers of male patients, victim survivors, often they were being perpetrated against by other men. So we need to recognize and recognize that that is relevant in both programs that we run. Okay. So thinking about the response, it's really important that we think about the language that we use when we're asking, responding, thinking about age, sexuality, and gender. So not assuming the gender of a patient or their partner, or if they have one, or if the person lives with them. So thinking about how we ask questions, particularly in sexual health setting, is really important. Also thinking about if English, in our case in the UK, if English isn't somebody's first language, ensure that there's appropriate interpreters. Is somebody deaf or hard of hearing? Do we need to ensure that there are appropriate ways of communicating? And the key thing that we put in all our training, and we shouldn't have to say it as many times as we do, but not using a partner or family member to interpret is really important as well. And I think as well that final point there, young people may be experiencing domestic abuse indirectly. So if we ask a general question about how are things at home, if the abuse isn't happening at home, it might be in a different relationship, then we might indirectly prevent that person from disclosing. So again, thinking about how patients might define relationships potentially in slightly different ways than we might expect, and just being open to that, to think about how we ask those questions. And thinking here about what do survivors say that they want from healthcare professionals. So it's really important we have that feedback loop with clinicians. So when we IRIS and advise advocate educators close a case, then they will feedback to clinicians, so they will know what's happened with that patient. But what they want is from professionals to feel comfortable and supported to disclose, to be asked directly. So having that low threshold for clinical questioning or that professional curiosity that I mentioned before, an immediate response to disclosure. So having a positive reaction, a positive, what we always say is we have many opportunities to ask. If you ask and somebody doesn't disclose, that's fine. You can ask again, or somebody else can ask again. The worst case scenario is if you ask, somebody disclose, and you don't have an appropriate response, because then that might prevent that individual patient from seeking help again. And a response in later consultation. So having that continuity of care. If somebody does disclose, making sure that you have that flagged in the medical record so that somebody could be asked again, oh, you mentioned this last time, how are things? Because things do change. We know risk changes, so it's important to think about that. I've got a final slide here. We're not expecting you to do counselling or therapy with clients, but what we do ask is that you think about having a trauma-informed practice. So being mindful and sensitive with patients, doing everything that we can to avoid re-traumatization, explain what we're doing, asking for consent, asking if they would like a chaperone, etc. But also being aware of the different ways that people present and the different ways in which people react to abuse. So some patients may be chaotic, some may be numb, some may be dissociated, some may be really angry. And being really angry isn't necessarily an inappropriate response. So just being aware that people will react in different ways and present in different ways, and having clear grounding techniques to hand if a patient becomes distressed. So trying to bring them back in the room, describe what they can see, hear, smell, just trying to get them to think, name things that they can see, telling them the date, reminding them where they are, reminding them that they're safe, etc. And we don't need to ask a lot of questions about the abuse in that trauma-informed practice. We only need to ask the questions about current safety and support, and being able to say, we are able to refer you to somebody who's got the expertise, who'll be able to help you and can talk to you about this in a safe environment if you want us to do that. And finally, involving patients in their own care, provide choices and options. So just before I come on to questions, I'm going to say thank you, and I'm going to stop sharing my slides